I'm very much hoping that in going through the scope of the problem with cardiogenic shock, I might be able to lay some of the foundations for all the excellent speakers that will be following. I have no disclosures specifically related to cardiogenic shock, but my research affiliations are listed there. So the pieces I'd like to take us through today are starting off with definitions. What is cardiogenic shock, which is a little bit more complicated than maybe it should be, and I'll be very interested in hearing the input of the panel as to what they think the correct definition should be. We'll talk a little bit about classifying the severity of cardiogenic shock and some of the paradigms in use for that. I'll cover the epidemiology and the prognosis, with, of course, the prognosis being a major reason why we focus so much on this condition. And lastly, just touch on contemporary management principles, which will be so much of a focus of the rest of this symposium. So starting here with the definitions. Taking the definition that's used in the 2017 AHA scientific statement, we can define cardiogenic shock as a primary cardiac disorder that results in both clinical and biochemical evidence of tissue hypoperfusion. And some authors may further define this primary cardiac disorder as one that causes a diminished cardiac output in the face of adequate or even elevated filling pressures, and yet is associated with tissue hypoperfusion. You'll see that in this definition, we do not have hypotension. And this is a very interesting area because, as many of you know, historically, hypotension has been a cornerstone of many of the trials and guidelines that have preceded us. So, for example, in the seminal shock trial, individuals needed a systolic blood pressure less than 90 for 30 minutes or more, or mechanical support to maintain that blood pressure above 90 in order to enter the study. And so there is a little bit of a tension sometimes in terms of should we be defining this condition more around the hypotension part of it or the low cardiac output part, because they're not necessarily synonymous. But more recent paradigms seem to really focus on the cardiac output piece. So there's an inciting primary cardiac disorder, a reduction in cardiac output, which in the classic paradigm would then be met by peripheral vasoconstriction and the systemic vascular resistance going up. Although we do know from existing literature that that's variable, and sometimes the SVR doesn't go up as much as we think it might. In part, that may be because of the SIRS syndrome coming in with release of IL-1, IL-6, and nitric oxide causing peripheral vasodilatation, and a variable amount of pulmonary congestion and underperfusion of both the heart, potentially further worsening the low cardiac output state, and of course underperfusion of the rest of the end organs, which unfortunately all contributes towards this downward spiral. Now, part of the difficulty here is that we've all met patients on sort of different ends of the spectrum. We have had certainly patients who do not have a low blood pressure at time of presentation, but clearly are hypoperfusing, may have a measured low cardiac output, and have those markers of end organ dysfunction, metabolically demonstrate their shock through having a lactic acidosis. And so both pieces of the paradigm are certainly present. I think the other important thing is that many of the studies that classify cardiogenic shock are looking at a single time snapshot when the patient enters the hospital. And as we know, patients progress through these paradigms. And so even the individual who does not have hypotension at the time of presentation may develop it later in their course as the SIRS piece and the systemic vasodilatation becomes more predominant. So just some thoughts around the pathophysiology, which we'll hear so much more about. I'm touching here on various ways in which the presentation of shock can be heterogeneous, and I truly believe that this contributes towards the scope of the problem that I'm speaking on. Heterogeneity also comes in the form of the very diverse inciting events that can be the reason for the primary cardiac dysfunction. With so much of our literature coming from the acute myocardial infarction space, and that being the cornerstone of what we know about cardiogenic shock, but there obviously being a very diverse number of non-MI etiologies that are incredibly important too. And at the end of the day, maybe we don't even have to think about, is it more about hypotension, more about low cardiac output, because really the two are so tightly interlinked. And using a metric such as cardiac power output or cardiac power index, using the cardiac index in this equation, is a way that we can sort of accomplish understanding of both of those and their relative contributions towards a patient's end organ dysfunction and metabolic shock. Whatever the inciting event may be within these heterogeneous etiologies, there are clinical signs that we hold to be common and that we often recognize as a presentation of cardiogenic shock, as listed here. These markers of end organ hypoperfusion, such as pallor, slow capillary refill, cool, clammy patient with decreasing urine output, and clinical signs of acutely decompensated heart failure. However, within this spectrum of clinical presentation, again, we have heterogeneity. And so, as we'll hear in some of the pathophysiologic and hemodynamic talks, patients may lie anywhere on a spectrum of predominantly left-sided, predominantly right-sided, or biventricular shock. Many patients are hypervolemic, but some have normal or even low volume status. We've already talked about the diversity of blood pressures at presentation, as well as the diversity of amount of cardiac ischemia. Some patients may have more of a mixed picture with a component of infection or other vasodistributive shock going on. And in some patients, they may have very advanced hemodynamic findings, but be less metabolically deranged. So trying to encompass all these pieces when we're learning about early recognition of shock and categorization of severity of shock does make it all quite a tall order to really understand the scope of this condition. In terms of that severity piece, there have been various efforts over the years to classify how affected an individual is upon presentation in cardiogenic shock. So some earlier paradigms were the pre-cardiogenic shock and refractory shock categorizations. But as many of you will now be aware, we more recently have this SKY pyramid that was published to really try to drill down and speak a common language in terms of our classification of shock severity. With an A, B, C, D, E categorization, A being those individuals who are at risk, C and D representing most of the type of patient that we're talking about in this symposium, either as the classic C patient or a patient in D who's deteriorating and showing worsening hemometabolic shock despite interventions, and then E being the extremist patient who is incredibly unstable. In terms of epidemiology, we do have to reflect the importance of etiology when we're looking at some of these epidemiologic studies and inferring prognosis from the literature that's out there. As I mentioned, the vast majority, maybe about 2/3 of cases that we see and that are out there in the literature, are an acute MI etiology. And the other non-MI etiologies smaller in their contributions epidemiologically. And this is important because if we're extrapolating information from some of the large registries that are very much acute MI based, they may or may not really reflect the expectations for our patient with a more diverse etiology. But suffice to say that in most registry data, we see that those individuals with an acute MI, shown in the Kaplan-Meier curve in red, tend to have a worse prognosis overall than individuals presenting with another non-MI etiology of their shock. In terms of temporal trends, there is some suggestion that there may be a slight decline in incidence of cardiogenic shock over the decades, potentially related to changes and improvements in the management of STEMI. Although there's some diversity of data, there's also a recent UK paper showing an uptrend, so it really depends how the definitions are drawn up. But in terms of estimating the scope of this condition, we know that between 5 to 8% of patients presenting with a STEMI and maybe 2 to 3 of non-STEMI presentations will result in cardiogenic shock. So that would give us 40 to 50,000 cases annually in the United States. And then if we add above that the non-MI cases, we're perhaps looking at a scope of 60 to 70,000 presentations annually. It can seem certainly as though the incidence may be going up, perhaps because of the ways we encounter these patients and the activities around management that we see. So on the top trend curve here, we see the use of intra-aortic balloon pumping over time for cardiogenic shock, but down below, use of devices such as temporary axial flow pumps and ECMO, obviously escalating quite dramatically over the last few years in terms of their utilization in this population. We'll move now to prognosis. I'd mentioned that the etiology of cardiogenic shock is very important when inferring the course that a patient may take, and certainly mortality does differ by etiologic group. So here you see both in terms of the intensive care mortality in orange and in-hospital mortality overall in blue, that those individuals who present with an acute MI etiology do tend to have a slightly higher mortality risk than those who are non-MI presentation. And overall, cardiogenic shock mortality is in the range of 35 to 40%. Clearly a high mortality condition, the exact numbers depending on what severity and what etiology we're looking at, but a high mortality condition. In the early days, with this literature from the 1990s, the mortality was classified by the therapy provided, and here we see a very striking difference in mortality rates between those who are not requiring vasoactive support and those who are requiring high doses of inotropes. And clearly that 80% mortality for 3 high-dose strips is an incredibly high one. Difficult to know if it's the presenting phenotype here that is responsible for that mortality, or if some of the treatment we're using in terms of vasopressors and inotropes is contributing to those very high mortalities on the end of the spectrum. And of course, in our current paradigm, as you'll be hearing about in this symposia, we now move more towards hemodynamic support with mechanical devices to try and offset some of those exacerbations of hemometabolic shock that may come from using the intravenous agents. Looking more contemporarily at the SCAI classification, we have this very nice data from Mayo Clinic, recently published, seeing a similar gradation in mortality as we move through the categories of increasing severity of shock as recently defined by SCAI. And of course, this is a very important paper that we'll no doubt be hearing more about during the conference, because it did validate this consensus opinion as what constituted milder versus more severe grades of shock, and really laid it out for us, at least at this single center, that we really do see the highest levels of mortality as we go through the increasing grades of severity up towards stage E. I do just want to also mention an important subgroup, which is women with cardiogenic shock. We do know that women tend to present older, more comorbid, and have a higher in-hospital mortality than their male counterparts. And we do have some suggestions, such as this paper from Susie Joseph, that women who receive earlier temporary mechanical support, in this case pre-PCI intervention with an Impeller 2.5, may actually derive even more benefit than men receiving early MCS support. We do also have the good news that along the lines of these evolving paradigms of team-based care for shock management, that we may be able to move the dial on survival in cardiogenic shock, and that, of course, is one of the reasons why symposia such as this is so important. We also know that over time, with more nuanced use and interpretation of the Swan-Ganz catheter and the hemodynamics we obtain, and also the institution of early temporary mechanical circulatory support, that we may be able to move the dial with some observational studies and notably the Detroit experience showing us that we may be able to get to the point of even 76% survival, as they have done in their cohort. To conclude and summarize, I'll leave you with at least what I think are the 3 main goals for surviving cardiogenic shock before we move on to our future additional presentations. So there are really 3 parts that we need to be cognizant of when managing these patients. We're looking at the heart and trying to unload the heart and rest it for myocardial recovery. We're looking to support and maintain or recover that end organ dysfunction that characterizes cardiogenic shock. Meanwhile, reversing the metabolic and inflammatory derangement that is taking place. So as we go through the symposia, we should just keep thinking about these 3 goals and 3 parts to the puzzle that are essential in overcoming shock. And I just leave you here with a word cloud I created. I put the 2017 scientific statement from the AHA into a word cloud and was very happy to see that patients really came out as the predominant word there. And of course, that's what we have to keep thinking back to, is our patients who are presenting very heterogeneically and with a great range of pathology here, but finding ways forward to take care of them is, of course, paramount. Thank you very much.
Thank you. So, panelists, thoughts, questions? Microphone, dig in.
Good afternoon. This is Philip Weeks from Memorial Hermann, pharmacist. Recently, a point was brought up during the talk, I guess she's left the podium, but about patients that are normotensive who present with shock. I think that's something that everyone recognizes as one of the major flaws with the historical definition. Recently, we had a patient who was just such this situation, came in basically normotensive, looking very ill, obviously, turned out to have severe myocarditis. I think one of the key things that helped us recognize it was actually, we had central venous access and sent a blood gas from we didn't have a Swan-Ganz catheter at the time, but obviously we could get a SCVO2. Lactate was still normal in this patient because it was literally such an early presentation, but the patient's SCVO2 was severely reduced, and this prompted a lot of discussion about escalation of treatment. The patient got a balloon pump and was started on inotropes before they really fell off the cliff like they would do. I just want to invite and ask, what are others' thoughts about using monitoring such as SCVO2 or SVO2 as an earlier sign of hypoperfusion, because we know that we see that before the presence of lactic acidosis in these patients. So I would ask, any other comments?
I think it's an excellent point you brought here to discussion. I think SVO2, if you don't have a SWAN in a patient, is a very important parameter, but you have to know what to do with SVO2, because you have to see that hemoglobin is okay, temperature of the patient is okay, and all other things are okay, that you can reflect your cardiac output and you can start to react based on that. It's an excellent point, and I think it's not, many hospitals are not placing a SWAN, but most of the patients in cardiogenic shock had at least a central venous line, and the simplest thing you can do, get a central venous gas and look to the saturation. It's going to give you a hint where is this patient staying.
These are all excellent points. I want to, Jake Jenser from Mayo Clinic, I really want to emphasize how important I think venous oxygen saturation can be as both a diagnostic and monitoring tool. And what's interesting is that in the general critical care literature, as many of you already know, there's a big movement away from SCVO2 monitoring because of the early goal-directed therapy clinical trials, and a lot of intensivists have conflated the negative results of early goal-directed therapy clinical trials with saying there's no value in monitoring SCVO2. And I know that it's certainly one of the first things that I think of when I get a call about a patient who has undifferentiated shock. The first question I ask is, well, what's their venous sat? And I think that as we think more about that, it's helpful to kind of integrate, the patients who clearly are cardiogenic, clearly are vasodilatory, but I think the increasingly recognized population that have mixed shock, and those are the ones that, as we saw the data, those patients do the worst. And so I think that we need to think more about how are we going to monitor our cardiogenic shock patients, because there's a lot of data from the sepsis literature about using serial lactates, renin levels, arteriovenous CO2 differences, and parameters that we don't routinely measure in our cardiogenic shock patients, but probably are even more relevant in our patients than they are in patients with sepsis.
It's on already. I agree completely. As the token pulmonary and critical care doc in the room, I have been outspoken from the very beginning as soon as ARISE, Process, and Promise came out to say this tells us nothing about the utility of monitoring central venous O2 sat and correcting it when it's abnormal, because unfortunately those studies tried to apply a protocol to people, at least half of whom already had a normal central venous O2 sat at the time. practice in an institution like many of you do, where we have a medical ICU and my cardiologists sneak away with all the good cardiogenic shock. So I'm not going to claim to be the sort of expert that you guys are at cardiogenic shock, but I think the point you just made is extremely germane, and as it happens, that's what my talk is about in a couple of hours. So I'll put in that plug.
May I ask the panelists their opinion of other clinical signs? I mean, in sepsis, we have seen the revival of the capillary refill time and other skin aspects quantified as mottling, scores, and others. Do you think that in cardiac shock, we also need to focus a little bit more on these early signs? And what is exactly the values of these? What is your opinion on this?
Well, if I get the patient early, I would focus on them. Unfortunately, our patient coming on multiple inotropes and drugs, and that's capillary fill is not going to work on those patients. If we have the patient as a first line, yes, but I think all of us here working with advanced patient coming to us after treated from other groups, and I don't think it's, at least in my case, is not going to help us.
I know there's some data that says that the different physical exam findings, some of them have greater or lesser prognostic value, things like mental confusion associated with very poor prognosis. But I think the challenge that I always struggle with is that many of these physical exam findings can be confounded by other factors. Certainly we know that the use of vasopressors can alter capillary refill time clinically, and certainly things like cardiac arrest would affect mental state. So I think it's a very astute question, because why do expensive invasive monitoring if you can get the correct answers by a careful physical exam? But I know that it's certainly challenging, I think, in clinical practice to do that until it's properly validated.
I don't have any specific comments, but I think, to the point that was made, physical exam, I think, is paramount, because I think in a lot of these patients who are, very difficult to diagnose in these early stages, they're showing signs that may not be as objective. And I think that, asking the questions of, what can add to your diagnostic parameters, whatever that may be, obviously some of them are already on certain therapies by the time they are received at different centers. In the talk, the point was made about the associated mortality with several inotropes or vasopressors. I would argue as a pharmacist, it's not the drug's fault always, but I think I want to add that certainly we need to recognize when drug therapy is failing, and when to escalate to mechanical circulatory support, because I think in this era that we're in, we know that there are limitations to the drugs that we're using. They still have value, but I think the value is being certainly replaced by devices.
We have one. Also kind of echoing the same thing in terms of by the time people really arrive to a majority of our centers with the advanced heart failure, they're on multiple medications. We don't really have the benefit of that physical exam. And I think a little bit of this is our partner or community partners being lulled into complacency, much like the patients you talk about who are still normotensive, maybe don't look great, but don't fit those very key hemodynamic parameters that everyone kind of says are absolutely cardiogenic shock. So we kind of miss that bias, or I guess that lead time of using the physical exam, because we know how powerful it is.
I only have a short comment. I enjoyed your talk, really good. The question or the comment I have, since we are in shock symposium and we are not in having only dealing with only acute MI shock, we're dealing with different forms of shock. I didn't see that it's sepsis or septic cardiomyopathy, anoxic cardiomyopathy, post-cardiotomy cardiogenic shock as an etiological factors. I think if you look also see the percentage of patients suffering from shock related to acute MI might be overestimated, because the others are underreported in the literature. And I think that the shock symposium we're having here should be part to try to get a balance between what we're seeing outside the cath lab and ICUs and what's the community doctors seeing and treating.